Hi there, I'm Dr. Sharnamoin and welcome back to my channel. Hope you all are doing good. I recently have started making videos which are specifically designed for medical students. So if you want to get updates about those educational videos, then please do subscribe my channel. So today I chose the topic diaphragmatic hernia, the hiatal hernia if I say more specifically. I know this topic is not really that easy. There are so many divisions and subdivisions of this topic which actually confuses the students a lot. So in this video, I've tried to explain things in a very simple way so that the confusions become clear and you can remember the topic easily. But before starting the topic, I want to request everyone, please do subscribe my channel because your support inspires me a lot to make a lot more new videos like this. So without wasting any more time, let's get started. We have to know what is hernia at first. Hernia is abnormal protrusion of any organ through an abnormal opening or through any weak point. So the important thing is abnormal protrusion. Let me to explain a little. Suppose there is an intact wall between two compartments. So let's draw this. So this is the intact wall and these two are the compartments. These organs are in high pressure in this compartment, of course, but they cannot come into this compartment due to the presence of this wall. But if there is an abnormal opening in this wall, suppose in this case, like I'm drawing here, suppose this is an abnormal opening. When these organs will find an opening in this wall, then sure they will protrude into this compartment, like this. So this is hernia. They always have a tendency to move from the high pressured area to the low pressured area. Now this process, if it takes place in the diaphragm, then that is known as a diaphragmatic hernia. So we have to know the normal anatomy at first. Now we can see the diaphragm. It actually acts as a barrier between the thorax and the abdomen. And the thoracic contents do not come into the abdomen, or the abdominal contents do not go into the thorax due to presence of this diaphragm. And if the organs somehow protrude into the thorax through the diaphragm, then that is known as the diaphragmatic hernia. There are already a few openings in the diaphragm, but through those openings the organs cannot pass because of their narrow diameter. Now if those openings somehow become dilated, or if there is an extra abnormal opening, then these organs will try to protrude into the thorax because the intra-abdominal pressure is always higher and is positive, and intrathoracic pressure it is lower and is negative. So the abdominal contents always have a tendency to protrude into the thorax. Now when there is an extra abnormal large opening, see, the abdominal contents will literally be sucked up into the thoracic cavity because I've already said that they have a tendency to move towards the low pressured area, and this will push the organs into the thorax. And this is the diaphragmatic hernia because this herniation is taking place in the diaphragm. So this picture is collected from the children's Minnesota. So you can see this picture is collected from the Children's Minnesota. I'll put on the link in the description box below so that you can easily find these pictures. They are really beautiful and easy to understand the process. Okay, so now let's talk about the types of the diaphragmatic hernia. So there are a few types. Number one is the herniation may take place through the hiatus of the diaphragm, and this is known as the hiatal hernia. And the herniation may also take place in the foramen of Morgagni or foramen of Bogdalek, or this is also known as the Bogdaлек's triangle. This is another type. And also if there is so sometimes there is congenital absence of a portion of the diaphragm, so herniation may take place through that foramen as well. And sometimes the diaphragm may get injured from from any sort of trauma, or from bullet injury or stab injury, anyhow. So if there is any accidental perforation in any place in the diaphragm, the herniation may take place through that foramen as well. In today's video we are going to talk about the hiatal hernia in details, and we'll discuss about the other types of hernia, like the herniation through the foramen of Morgagni or through the foramen of Bogdalek. About these types of hernia we will discuss in our next video. So first things first, the hiatal hernia. And from the name you can understand that this herniation takes place through the hiatus. And we already know that the diaphragm has three major hiatus. One is the vena-cava opening or the vena-cava hiatus, then we have the esophageal hiatus, and we have the aortic hiatus. Now the herniation or the diaphragmatic hernia, it takes place in the esophageal hiatus more specifically. Through the esophageal hiatus, the esophagus passes from the thoracic cavity into the abdomen. So let's talk about the parts of the esophagus. So suppose this is the neck portion, thoracic portion, and abdominal portion. Now this is the esophagus, and the portion of the esophagus that lies in the neck region or in the cervical region is known as the cervical part, and this portion which is in the thoracic cavity or in the thorax is known as the thoracic part of the esophagus. And this lower portion, which you can see is in the abdomen just below the diaphragm, is known as the abdominal portion, and this portion becomes continuous as the stomach, and this is known as the gastroesophageal junction here. So we can say this abdominal portion and the gastroesophageal junction, both of them, they should always be in the abdominal cavity below the diaphragm. Now if we look at the longitudinal section of this portion, we'll find a figure like this. So see, the lower portion of the esophagus, the muscles suddenly became dilated, or we can say thickened. So this thickened portion is actually forming the lower esophageal sphincter, as it is residing in the lower portion of the esophagus, and it acts like a physiological sphincter. So this is known as the lower esophageal sphincter. So we can say that the abdominal portion of the esophagus, the gastroesophageal junction, and the lower esophageal sphincter, all of them, they always have to be in the abdominal cavity. They should never ever be present in the thoracic cavity. There are a few factors that are responsible for maintaining this condition. Number one factor is the diameter of the hiatus. This diameter is about 1.5 centimeter in normal condition, and the diameter of the thoracic part and the abdominal part is about 2 centimeter. So the 2 centimeter esophagus cannot pass through the 1.5 centimeter hiatus. They have a larger diameter than the hiatus. So this is one of the most important factor, that is the diameter of the hiatus. The second important factor for maintaining this condition is the Fresno-esophageal ligament, and from the name you can understand that there's a ligament which actually anchors the Fresno, that means the diaphragm, with the esophagus. So let's see, these two are the upper Fresno-esophageal ligament, and these two are the lower Fresno-esophageal ligament. You can see that this is the diaphragm, okay, and these ligaments are anchoring the esophagus with the diaphragm. That is why these ligaments are known as the Fresno-esophageal ligament. There are two upper Fresno-esophageal ligament and two lower Fresno-esophageal ligament. So they actually keep the esophagus in its anatomical position, and the esophagus cannot move from its original position. And you can see that these are the ascending limb or the upper limb of the ligament, and this is the lower limb of the ligament. See, descending limb or the lower limb, and ascending or the upper limb of the Fresno-esophageal ligament. So these are the factors that are maintaining this condition. I mean, this is why the esophagus actually cannot move upwards because of the narrower diameter, and also for the Fresno-esophageal ligament. And here in this picture we can also see a zigzag line here, and this is the esophagus and this is the stomach. So this portion is known as the gastroesophageal junction. Okay, so this zigzag line, see, zigzag or Z line, this is actually the gastroesophageal junction. Okay, so the gastroesophageal junction, it always remains below the diaphragm. Now let's see why and how this herniation takes place through this hiatus. So we will discuss about that now. Now if somehow the hiatus becomes dilated, that is if it becomes more than 2 centimeter, then the contents of the abdomen will try to protrude into the thorax through that space. Or if the Fresno-esophageal ligaments, if they become loose or torn, then there will be no support. Then the esophagus and the other abdominal contents will try to push themselves up into the thorax for the positive intra-abdominal pressure. There are so many reasons for which the ligaments may become loose or torn. It may become loose in age-related degeneration, or as these ligaments are made up of connective tissue, so in connective tissue disorders like Marfan syndrome or Ehlers-Danlos syndrome, in those disorders, these ligaments may become loose. And also, herniation may take place if there is shortening of the esophagus. This is very obvious that if any portion becomes shortened, then it will actually pull up the abdominal portion or other abdominal contents into the thorax, right? Now, why there is shortening of the esophagus? If there is an injury in the esophagus and stricture develops, then of course there will be shortening of the esophagus. And how the esophagus may get injured? Very simple. If someone swallows the acid or other corrosive substances, even from the chronic gastroesophageal reflux disease, in which the acid is refluxed from the stomach into the esophagus, then the esophagus gets injured, and in that case the contracture may develop. So these factors are responsible for shortening of the esophagus, which may lead to the hiatal hernia. So I have described the most common factors that are responsible for the hiatal hernia with their mechanism. So now let's talk about the types of the hiatal hernia. The first one is the normal case, and the second one is the sliding hiatal hernia, and the third case, this is the rolling hiatal hernia. They have represented the esophagus with the light pink color, yes, and the stomach with the dark pink color. So you can see the junction there, the junction between the light pink and the dark pink, the gastroesophageal junction. That junction that is situated below the diaphragm. So this is a normal case. So the gastroesophageal junction is below the diaphragm and as well as the fundus of the stomach. Now see the next case, the sliding hiatal hernia. Here the gastroesophageal junction. Now in this case they are not below the diaphragm, they have slided up into the thorax. So this is sliding hiatal hernia. But the fundus of the stomach, it is still in its normal position. So the next case, the gastroesophageal junction, this is in its normal position, that is just below the diaphragm, but the fundus of the stomach, which was supposed to stay in the abdomen, they have rolled and then moved up into the thorax. This is known as the rolling hiatal hernia. So in case of rolling hiatal hernia, you have to look for the fundus of the stomach, and in case of sliding hernia, the gastroesophageal junction is important. And the rolling hiatal hernia, they actually do not depend on the gastroesophageal junction. Here the junction may or may not remain in the normal position. So it does not depend on this. If the fundus of the stomach rolls upward, then that is rolling hiatal hernia. So that is the thing. So this is a more clear picture showing the sliding and rolling hiatal hernia. The first picture is clearly the sliding hiatal hernia as the gastroesophageal junction. You see the junction between two colors. So this one, gastroesophageal junction, it has moved up above the diaphragm through this hiatus. So this is sliding hiatal hernia. Okay, but in this case the junction is in its normal position, but the fundus of the stomach, it has moved up. So as the fundus moved up, this is known as the rolling hiatal hernia. So the sliding and the rolling, two types of hernia. Now we will talk about the subdivisions. Okay, this is a very nice illustration showing the different types of hernia. So the first picture you can see, I have already said that the lower end of the esophagus, it becomes dilated, and that actually forms the the lower esophageal sphincter. Okay, this is lower esophageal sphincter, and you can see the zigzag line, or you can say the Z line, and that is the gastroesophageal junction. Okay, both of them, they have to be in the abdominal cavity, just below the diaphragm. Okay, so this is the diaphragm. But in this case, see the picture on the right. Here you can see the dilated portion, that is the the lower esophageal sphincter, and the gastroesophageal junction. You see the two portion, the darker portion and the lighter portion, there is a junction, the zigzag line. So that gastroesophageal junction and the lower esophageal sphincter, both of them, they have moved upwards, and they are now above the diaphragm. So this is obviously hernia. And what type of hernia? This is sliding hiatal hernia. As I've said, that if the junction moves up, then that is sliding hiatal hernia. Now here in these cases, you can see the fundus of the stomach has moved up. You see the fundus here in the first case, the second one, third one, the fundus has moved up. So these are the rolling hiatal hernia. As I've said earlier, that if the fundus moves up, then that is rolling hiatal hernia. Now let's talk about the subdivisions, and we can clearly see that the first one, I mean the sliding hiatal hernia, it does not have any subdivision. There's only one type where the junction moved up, gastroesophageal junction, it moved up, and this is known as type 1 hiatal hernia, and there's no other subdivisions in this case. But we can see in the rolling hiatal hernia there are many subdivisions. The first one, the fundus has moved up, but the gastroesophageal junction, it did not move up. It is still in its normal position, that is below the diaphragm. So this case where the fundus moves up but the junction does not, that is known as the type 2 hiatal hernia. In the second case we can see the fundus has moved up and the junction as well. So both the junction and the fundus, both of them moved up. This is known as type 3 hiatal hernia. Now we can also say that the junction moved up, so obviously this is a sliding hiatal hernia, and as the fundus moved up, this is also rolling type of hernia. So there is both sliding and rolling type of hernia. So this is also known as mixed type of hernia. Okay, so type 3 is actually mixed hernia. Now let's go to the next picture. Here the junction moved up, the fundus moved up, and also in addition some abdominal contents like the intestines here in this picture may also protrude through the hiatus. If this happens, then this is known as the type 4 hiatal hernia. Type 4 hiatal hernia is actually a more severe form of the type 3 hiatal hernia. This is also a mixed hiatal hernia. As we can see, there is a sliding hiatal hernia and also rolling hiatal hernia. So these are the types of the hiatal hernia. In the next picture, they have showed the normal anatomy, that the lower esophageal junction and the lower esophageal sphincter and the gastroesophageal junction, both of them, they are situated below the diaphragm. So this is obviously a normal case, but below, in the first case we can see only the junction moved up, the fundus is in its normal position, so this is sliding hiatal hernia. But in these cases, see, the fundus moved up, so these are rolling hiatal hernia. In the last two cases we can see there is a sliding hiatal hernia and also rolling hiatal hernia, sliding and rolling, so these two are mixed hiatal hernia. Okay, now let's talk about some pathology. To understand the pathology, we must have a clear idea about the normal anatomy and physiology at first. I have already said a while ago that the lower esophageal sphincter, you see, it has to be below the diaphragm, and the hiatus of the diaphragm, esophageal hiatus, it remains in the muscular portion of the diaphragm, and that literally can contract and gives a support to this sphincter. It acts like a physiological sphincter. Okay, when the hiatus, the muscles of the diaphragm, they contract, this portion also gets a support, and the content of the stomach, they cannot regurgitate due to presence of this physiological sphincter. And we actually do not want the content of the stomach to be in the esophagus, because in the stomach we have acid and other corrosive substances which are actually harmful for the esophagus. Now if this portion, I mean the lower esophageal sphincter or the gastroesophageal junction, it moves up into the thorax, see, then there will be no support. Then the contents of the stomach, they can easily regurgitate into the esophagus and may cause injury. And you can already see the acidic fluid of the stomach, they have already eroded the lower portion of the esophagus. So erosion has developed, we can see. So the esophagus got injured. So in type 1 hiatal hernia, let's see. In type 1 hiatal hernia, the gastroesophageal junction along the lower esophageal sphincter, they actually moves up into the thorax. So there will be no support anymore, and the contents of the stomach will go up and will erode the lower portion of the esophagus. Now this regurgitation or reflux of the gastric contents into the esophagus, this is known as the gastroesophageal reflux disease. That means from the gastric to the esophagus it is refluxed, and this disease is known as the gastroesophageal reflux disease. So in type 1 the patient will face gastroesophageal reflux disease. Okay, now in type 2 the junction is in its normal position, right? So the physiological sphincter is okay, so there will be no GERD. GERD means, you know, I have already said, gastroesophageal reflux disease. There will be no gastroesophageal reflux disease. But the problem is, in the hiatus, in normal condition, only esophagus was present. But now we have the fundus of the stomach in addition. So in this case, this fundus of the stomach, this is actually pressurizing or smashing the lower end of the esophagus. So if we take any food or anything, that will not pass through this region properly. So we will face the difficulty in swallowing. That is known as the dysphagia. And we may also experience painful swelling, which is known as the odynophagia. So in type 2 hiatal hernia, there will be no gastroesophageal reflux disease as the junction is in its normal position, but there will be dysphagia and odynophagia because of the pressure from the fundus of the stomach on the lower end of the esophagus. So that is about type 2 hiatal hernia, and this is type 3 hiatal hernia. You can see both the junction and the fundus moved up. In this case, as the junction moved up, so there will be no support on the physiological sphincter, so there will be reflux of the gastric contents into the esophagus. So this patient will have GERD. In addition, it has the fundus of the stomach which is pressurizing the lower end of the esophagus, so he will also face the dysphagia and odynophagia. So in type 3 there will be GERD, dysphagia and odynophagia. Now the type 4. This is a very complicated case, and this is actually a surgical emergency. There is no time to waste in this case. As the junction moves up, the patient will face GERD. As there is pressure from the additional structures, the fundus and other structures, he or she will face the dysphagia and also odynophagia. But there are some serious additional complications. So let's see. See, this is the diaphragm and this is the hiatus. It became so much dilated that the portion of the liver, then the stomach, and the stomach has the greater omentum or lesser omentum. Then you can see the spleen, then you can see the large intestine and the small intestine, and the intestine have the mesentery attached with them. So along with the mesentery, they can enter into the thoracic cavity and they can compress the structures into the thorax. Let's compare this case with a normal one. In the left side, this is a normal case. In the right side, this is a case of the diaphragmatic hernia. Hiatal hernia. In the normal case, see, there are two lungs. They are in normal condition. Very good, very nice. And you have the diaphragm, and below you have the liver, the stomach. This is the large intestine, then small intestine. Okay, these are the structures. Now, when the hiatus became so much dilated, then the portion of the liver went up, then the stomach with the mesentery, and the stomach with the omentum, the intestines with the mesentery, and I can see the spleen over there. So these things, they went up into the thorax. So what happened? You see the condition of the lung here, very nice, but here from the compression of these structures, see the condition of the lungs. This is pulmonary hypoplasia, and also as they're compressing, the baby or he or she will face the respiratory distress, and also the intestines here in the thorax, they may get obstructed, intestinal obstruction. So in that cases, the bacteria from the feces and others, they actually colonizes there and may cause the infection, and the infection may spread into your blood, and that may lead to septicemia. So In this condition, I mean type 4 hiatal hernia, you will have the pulmonary hypoplasia, respiratory distress, intestinal obstruction, septicemia. And just like before, as the junction moves up, the patient will have GERD, and from the compression of these structures, the patient will face dysphagia and also odynophagia. So in type 4 hiatal hernia, all these conditions will be seen. So that's all about the hiatal hernias. Now this is the summary. You can see the type 1, type 2, type 3 and type 4 hiatal hernia. When the junction moves up, then this is known as type 1 hiatal hernia. When the junction is in normal position but only the fundus moves up, then that is known as type 2. In type 3, both the junction and the fundus moves up, and in type 4, the junction, the fundus and some additional structures, all of them, they move up. And the type 1 is also known as sliding hiatal hernia. Type 2, 3 and 4, they are known as rolling hiatal hernia. In sliding hiatal hernia, the junction moves up, and in rolling hiatal hernia, the fundus moves up. See, these are the fundus. But if both the junction and the fundus move up, then they are known as mixed. So the last two types, type 3 and type 4, they are mixed, and type 4 is actually the more severe form of type 3 hiatal hernia. So and in summary, the complications, type 1, the patient will face the GERD. Type 2, there will be no GERD, there will be only dysphagia and odynophagia. Type 3, the patient will have GERD, then dysphagia and odynophagia. And in type 4, there will be GERD, dysphagia, then odynophagia, pulmonary hypoplasia, respiratory distress, and intestinal obstruction, septicemia. So that's all about the complications and things that I know about the hiatal hernia. So in this video we have discussed about the hiatal hernia mainly. In our next video we will discuss about the other types of hernias. We will discuss about the herniation through the foramen of Mercagni and foramen of Bogdalek, and we will also discuss what these foramen or triangles are and where they are situated, and of course the herniation through these openings. So I hope this video was helpful. Thank you very much for watching. If you think that these videos are helping you, then please give a thumbs up, and please do subscribe my channel, because your support inspires me a lot. And if you have any question regarding this topic, or if you have any suggestion, then you can leave your valuable comment in the comment section below. So see you all in my next video. Till then, take care and goodbye.